What's that, bro?
This? Oh, I was missing the scalar, the cherry scalar, like I said.
I wanted to finish the thing I was studying. And I decided to read for mental.
That's it.
How they do it?
I feel you, man.
Just like, okay, yeah. I'll just do it. It goes to
You know which disease is the,
I don't know.
no, you know this one. What was the mouse space?
Space?
Oh. It is, I just studied it. It's systemic sclerosis.
That's also the one for the rash, isn't it?
Oh, that one is lupus erythematosus.
The one that
The,
has
the butterfly one, right?
the one that has the face mask.
Yeah, the face mask. Yeah,
It's the same one, right?
Good morning, everybody. I believe you have a test after this. Is that right?
No.
No? Oh,
I was
okay.
just reviewing.
Oh, okay. I saw you reviewing.
Yeah.
So today I'm going to, talk about two topics. One would be the GI. So we talk about like some of the gastrointestinal diseases and or symptoms, and how we utilize medications to treat those or relieve the pain and discomfort. And then also, hopefully in the second part of the class, I'm going to talk about anxiolysis or utilizing anxiolytic agents for sedation. So two topics basically. The reason for that is, unfortunately or fortunately for you, next week I cannot come to the class. So next week I have an last minute meeting that I have to attend to that. So I'm going to talk about our next week topic today too. So we have two topics today. And the exam would be on May 9. Okay? May 9 in the morning would be your sectional 2 exam.
So then we won't have class next week?
No, not with me.
Okay.
So it's good for you,
Yeah.
but I miss you. But it's a good time for you to study for your other class or for the exam. And I give you the study guide most probably this Saturday or Sunday. A study guide for the exam 2, which is on May 9. If you have any questions, let me know. You can come to my office during the week so we can talk. There was a question back there? No question?
Does it start at 9 a.m.?
The exam, yes. So, good question. The exam on May 9th is going to be started at 9 a.m. Okay? And again, if you remember, I talked to you before, on that day there is no case. So we talked about the case number 2 later. So on May 9th, you just have the exam. So let's start with the GI and the therapeutics. Just Okay. Do you have this? I just, okay. And we should have another set of slides after that. Okay. So, today we are going to cover GERD, PUD, constipation, diarrhea, nausea, and vomiting. For the most part, again, we are focusing on pharmacology and the medications that we can utilize to relieve these conditions. Okay, starting with GERD. GERD is gastroesophageal reflux disease. So what it does mean is that the gastric content basically comes up to the esophagus. So it causes burning sensation, it causes erosion to esophageal wall and mucus, and if it's not treated, it can cause ulcers on esophageal mucus. So treatment is extremely important for two reasons: to relieve the pain, discomfort, and burning, like heartburning, and to prevent any ulcer or possibility of esophageal cancer. So the reason for this situation is there is a sphincter. There is a sphincter between the stomach and esophagus, and usually that sphincter has a good tone, muscle tone. So if that sphincter lose the muscle tone, then the gastric content can comes up easily. So with the pressure or some foods that cause a loosening of that sphincter can cause the gastric content to comes up. So, and gastric content, as you know, it's very acidic and it contains enzyme. So it can be very, basically, irritating to the esophagus mucus. So just the content goes up. The sphincter is right there above the stomach. So it's right below the esophagus, above the stomach. That's lower esophagus sphincter, or LES. So the other name for that, if you look at when I talk about decreased lower esophageal sphincter, it's LES. That's the sphincter that, unfortunately, it's getting loose, and then the gastric content comes up. Okay, these are the pharmacotherapy options to treat the situation. So basically, we can use antacids, H2RA. What are H2RA? Do we have any H1RA? What? Very good. So H1RA are histamine type 1 receptor antagonists. Like what? Benadryl. Very good. Anything else? If you remember, Benadryl or diphenhydramine is histamine type 1 receptor antagonist. We use it for allergy. Is that right? Do you remember any other antihistamine? Do you remember loratadine? It's also H1RA or H1RB. We can call it histamine type 1 receptor antagonist or histamine type 1 receptor blocker. The same thing. These are the ones that we use for GI diseases are H2, histamine type 2 receptor blockers. So that's different. The other options would be PPIs. Do you know what is PPI? P is, question?
Proton pump inhibitor.
Very good, thank you. Proton pump inhibitor. Can you give us an example? Sodium potassium chloride?
Pump?
You said sodium potassium chloride?
Pump.
Oh, pump, oh sorry. Okay, sodium potassium pump. Okay, good. No. Prilosec, very good. Prilosec is a brand name. By any chance, do you know the generic name? That's right, Prilosec is one of those. Omeprazole. So PPIs, thank you very much. PPIs are among the drug classes that have very long acting effect. So starting from antacids, we have short and fast effect. then antihistamines, type 2 receptor blockers, and then PPIs or proton pump inhibitors. And if patients are not responsive to any of these medications, we can use prokinetics. I'm going to talk about each of these classes individually. Okay, antacids. So antacids are antacids. So they just neutralize the GI acidity. So they increase the pH. Because in normal situation, what is the pH of the stomach? About 2. So it's very acidic. Okay? So when we use antacids, something like calcium carbonate or calcium acetate, those medications increase the pH. So they decrease the acidity. So if a patient or if a person has like a GERD, so the content of the stomach is coming up, at least it's not burning anymore. So it's not that irritating. So that's one option. One advantage about antacids would be they are very fast. They act very fast. Why? Because they just go to the stomach locally, they stay there, and they just increase the pH. So they are fast reliever.
So when we have a patient in our dental chair and they're laid back to supine and they have GERD, are they gonna like spit up? Or not spit up, but is it gonna feel like they're gonna choke because of that?
Oh, okay. Good question. So actually a lot of patients, when they lay down, it's getting worse, of course. And one thing you can do is just change the angle of the chair a little bit so they have some kind of degree, like 30, 40 degree from the horizon at least. The other thing is if they can take some water at least to just wash the esophagus so they don't have that burning sensation, because sometimes the burning sensation causes cough. And that cough during the dental procedure is not great, I think. So, but the other thing is, if they have tums, tums, antacids, tums is calcium carbonate. So it's a very simple antacid. They can take a tums right there. In a few minutes, they get a good relief. So in general, antacids, one thing I want you to remember is they are fast-acting. They are fast-acting and they are short-acting. So we do not use them for long-term treatment. They are not effective for long-term treatment. They are good for mild or infrequent symptoms. So as needed, if the patient has heartburn, the patient can take 1 or 2 antacids. Okay. There are a couple issues with antacids. First of all, as I mentioned, they change the gastric pH. So when we change gastric pH, we change absorption of some medications. Do you remember from pharmacokinetics that one of the factors that affect absorption is the pH of the environment? So when we change the environment, it can be good for some medication, it can be bad for some medications. So we basically change the absorption of some drugs. The other important thing that it's really important for you to know is antacids may chelate, may bind to other medications. And there are some antibiotics that they might bind to antacids. So if the patient is on tetracycline, for example, and take antacid, the calcium or magnesium part of antacid binds to tetracycline and doesn't let it to be absorbed, which is not good. So chelating effect, changing gastric pH is very important. And we have to be careful about those. What we can do, what do you think we can do to minimize this? So we have drug-drug interaction. What we can do to minimize the issue?
Stop one of those.
Don't.
Don't put them together.
Very good. Very easy. Thank you. Don't give them together. So if the patient needs to be on antacid, if the patient has heartburn, take the medication now. In an hour or two, take the other medication. Sometimes it's hard though, because with antibiotics, we usually do not want to delay antibiotic. So with antibiotics, we never want to say to the patient, you know what, take your antacid first. After a couple hours, take your antibiotic. Antibiotics need to be on time. So what we can do is educate the patient. If you have frequent like discomfort and heartburn, if you are on antibiotic, take your antibiotic on time and then take antacid in 1 hour or 2 hours. Because the one is more important to get absorbed is antibiotic. So we wanted to take it first. Okay, so this is just what we talk about. And this is 4 to 8 hours is very, very conservative kind of recommendation. So a couple hours would be okay. As long as the first medication goes to the stomach and then eventually moves to the intestine, the second medication is safe to be given. So 1 to 2 hours for the most part. These are examples. Calcium, the brand name for that, calcium carbonate, one of the famous brand name would be Tums, and there are other brand names available. We also have antacids containing aluminum, magnesium, and sometimes we have magnesium and aluminum or magnesium and calcium together. So if you think about antacids, think about this kind of combination. Either aluminum, calcium, or magnesium. Okay. Now, there are a couple important points here that I want you to know, and it's very important for your test and possibly board and for your general information. So, when we are talking about calcium-containing antacid, one of the major adverse drug reactions would be constipation. So if I ask you what would be one of the major adverse drug reactions for calcium-containing antacid, it would be constipation. The same thing with aluminum. And the opposite way is with magnesium. So one of the adverse drug reactions with any kind of magnesium-containing medication would be diarrhea. So if the antacid is magnesium-based, it can cause diarrhea. If the antacid is calcium-based or aluminum-based, it can cause constipation. Is that for all patients? No, not necessarily. But a good number of patients get either constipated with calcium or get diarrhea with magnesium. And that's the reason that in some products we'll see the combination. So we have antacids, it contains magnesium and calcium. So they balance each other. You have questions?
I just want to make sure. So you said anything that has magnesium causes diarrhea or just the antacids?
Magnesium.
Anything that has it?
If the antacid is magnesium based, it can cause diarrhea. If it's calcium or aluminum, it usually causes constipation, if any. Okay. The second class of medication. So, a couple things about antacids. First of all, they are fast. Okay, they act very fast. They are short acting, and think about drug-drug interaction. They may bind to other medication. They may change the gastric pH, and the other thing is the adverse effect, which is either constipation or diarrhea. The other class of medications that we can use in gastroesophageal reflux would be H2R blockers or H2R antagonists. So these are basically antihistamines. But these antihistamines bind to histamine type 2 receptors. With histamine, we have different receptors in our body. We have type 1. Usually we block type 1 in the case of allergy. Type 2, usually we use type 2 blockers like this for GI issues. And type 3, I don't know what we use them for. I don't know if there is any medication, but I know there is a type 3 histamine receptor also. So for these, let me see. First of all, they are not as fast as antacids. So they take a few hours to affect. And the other thing is, there is not that much of benefit to add these medications to PPIs. So if a patient is on proton pump inhibitor, there is no need to add an antihistamine, because basically PPIs have a very comprehensive coverage. So if a patient is on those, we usually don't need to use these agents. These are the agents. Famotidine, so tidines, they all end with tidine. Famotidine, ranitidine, nizatidine, and cimetidine. And a good number of them are available over the counter. I believe ranitidine and nizatidine are both available. Even famotidine, Pepsid, I believe it's available. So patients can just go to pharmacy and buy it. A couple important points about adverse drug reactions. First of all, in regards to cimetidine, the last one, Tagamet or cimetidine, the adverse drug reaction would be gynecomastia in men. So that's one of the major adverse drug reactions, and that's one of the reasons that cimetidine is not popular anymore. It was one of the first H2R blockers came to the practice years ago, many years ago, 40, 50 years ago. But after that, other antihistamines came to the market with no adverse drug reaction like that. So cimetidine is not in practice that much anymore. I don't want to say it's not at all, but we don't see that much anymore. The other problem with cimetidine would be drug-drug interaction. Cimetidine is an inhibitor of cytochrome P450. So just think about drug-drug interaction. Others, they don't have that problem. In general, antihistamines like H2R blockers are pretty safe medications. They have a benign profile of adverse drug reactions. In general, when we are talking about antihistamines, though, there are some CNS side effects. Up to some degree, they may cause confusion, dizziness, and especially in elderly, we just wanted to be more careful. Not like histamine type 1 receptor blockers, not like diphenhydramine, but still some levels of confusion and dizziness can be caused by these agents. And one important thing, look at the last bullet, they may increase the risk of pneumonia in hospitalized patients. And the reason for that is they change the stomach pH, so like gastric bacterial flora can be changed. And it can cause overgrowth of gastric bacterial flora, and eventually they can migrate to trachea and bronchi and cause respiratory infection. So changing the pH for long term, could have some adverse issues. Okay. So compared to antacids, antihistamines are slower acting. That's one of the major differences. PPIs block gastric acid secretions by irreversibly binding to proton pump ATPase, which is basically a pump that releases acid or hydrogen ion into the stomach. So basically what they do is they block the acid pump, and they block it irreversibly. So they are very long acting. So are they good? Yes, they are extremely effective. So in the treatment of heartburn or reflux or ulcers, like GI ulcers, PPIs are very effective medication, long acting. But remember, we cannot use them as needed. We use short-acting medications like antacids for as-needed uses. We do not use these for as-needed. These are for maintenance, for long-term or scheduled use. And these are the agents, prazoles for the most part. So pantoprazole, esomeprazole, lansoprazole, omeprazole, like Prilosec, as you mentioned, rabeprazole, and dexlansoprazole. So as long as you remember prazoles, these are all proton pump inhibitors, long-acting acid-suppressing agents. Okay. And this medication is one of the older used medications to treat GERD. We call it prokinetic. Metoclopramide has different effects on different receptors. So it's anti-dopamine, and it has some cholinergic agonistic effect. So it has positive effect on cholinergic receptors and blocking effect on dopamine receptors. It increases peristalsis, so it increases the bowel movement. So with increasing the bowel movement, you have basically decrease in reflux. It increases the LES tone, so it increases that muscle or sphincter tone between the stomach and esophagus. So it prevents the reflux. And let's see what else is important here. I think for the most part, what I want you to know is the very first bullet, the mechanism of action. So this prokinetic agent has some dopamine antagonistic effect, enhances response to acetylcholine, so it's cholinergic agonist, and it's also anti-serotonergic. So if you see these in the exam, these are all the receptors affected by metoclopramide. Overall, what does it do is it increases the peristalsis. It increases bowel movement, so the gastric content does not comes up, basically. Contraindication, metoclopramide is contraindicated with GI obstruction or perforation. Why? Because if the GI is obstructed, if there is a tumor there, or if there is a perforation, we do not want to increase the motility. We make everything worsen. So in patients with obstructions or perforations, this is contraindicated. Also, we avoid metoclopramide in Parkinson's disease. Do you know why? Did you have Parkinson's disease in your disease state courses? Okay. By any chance, do you know what's the issue in Parkinson's disease? They're shaking, okay, or they are not able to move, okay? So what is the neurotransmitters that in body there is lack of enough a neurotransmitter that causes all these issues? Dopamine. Very good. Very good, thank you. So all these movement disorders are due to lack of dopamine or lack of sensitivity to dopamine. So if we have a medication which is anti-dopamine, it makes the Parkinsonism even worse. Okay? So we do not want to use this medication if the patient has Parkinson's. Any questions about GERD? So which classes of medication did we have? Antacids, antihistamines, but remember type 2, not type 1. Okay? PPIs and prokinetics. So these are the medications that you will see in a good number of your patients. There are a pretty good number of patients on one of these or a combination of these. Sometimes patients are on PPI or on antihistamines, like they are on Pepsid or famotidine, and for as needed heartburn, they are on antacids. So you may see this very common in your patients. Okay, peptic ulcer disease. So peptic ulcer disease basically is mucosal erosion of the GI. It can be gastric, it can be duodenal. So it's ulcer on the gastric or duodenal part. Three most common causes of peptic ulcer disease would be either infection by Helicobacter pylori, NSAID use. So if the patients are on high doses of NSAIDs, can you give me some examples of NSAIDs? Ibuprofen, very good. Anything else? Naproxen. Naproxen is even worse than ibuprofen. Any other examples of NSAIDs? Celebrex, very good. The best one, yeah. For GI, it's the safest one. So that's a good point. If the patient has like history of GI ulcer, Celebrex or celecoxib is the generic name, is the safest one. So if your patient has, let's say, a history of peptic ulcer disease or an active peptic ulcer disease, we probably want to avoid naproxen. We probably want to avoid ibuprofen because those may worsen the situation and may cause bleeding. So we have to be very careful in patients who have history of ulcer when we wanted to recommend or prescribe NSAIDs for them. And also a stress ulcer is another cause for peptic ulcer disease. And a stress ulcer happens when patients' endogenous cortisol level goes up at the time of stress, like very, very severe emotional or physical stress. When the cortisol level goes up, it causes less protection of GI lumen or GI mucosa, and that can cause ulcer. Okay, in regards to the NSAIDs, especially for you, for your profession, dental professionals, you have to be very careful. Again, NSAIDs are heavily used after dental procedures. They are very safe medication. Do they have analgesic effect? Yes, definitely. Do they have anti-inflammatory effect? Yes, especially if you increase the dose, they have more anti-inflammatory effect. What would be the major adverse drug reaction of NSAIDs? GI, stomach, pain or ulcer. Do you remember what was else? There was another major adverse drug reaction. Bleeding, very good. Okay, there's a third one then. No, bleeding is a big one. So GI, kidney, very good. So kidney dysfunction, GI ulcer, and bleeding. So whenever you think about NSAIDs, these three things need to be considered. So long-term NSAID use, high-dose NSAID use is not safe. That's the whole point. Okay. And for the GI ulcer or peptic ulcer disease, there are some cytoprotective agents that we can use, like sucralfate. Sucralfate or Carafate. Carafate is the brand name of sucralfate. It's a coating agent. So it's just like a kind of Band-Aid, but it's chemical Band-Aid. So sucralfate has aluminum, which is going to bind to the the protein of the ulcer. So it coats the ulcer and it protects it from the acid. So if there's an ulcer there in the GI lumen, it prevents the acid to irritate that ulcer. So that's a way to treat the pain at least. And one thing we have to make sure to remember is in sucralfate, a part of the medication is aluminum. And if the patient has renal insufficiency, we just need to be careful about aluminum accumulation. Other medications that we can use to treat peptic ulcer disease would be PPIs or H2R blockers. So the same medication for GERD, proton pump inhibitors or antihistamines, type 2. Again, the issue is there is an ulcer there, acidity, enzymes. We need to either increase the pH, prevent the acid secretion, or protect the ulcer from being exposed to acid. If you have any question, please ask. Question?
What you said about PPI and
Oh, okay. I just said, whatever we studied for GERD, they can be used for peptic ulcer disease also. So PPIs and antihistamines, they can also use for peptic ulcer. And always remember, if you have a patient either with peptic ulcer or reflux disease, for fast relief and short-term relief, they always can use antacids. So antacids are just PRN medications, as needed medications. Okay. The next GI issue that we are going to talk about is constipation. So constipation can be caused with many different reasons. There are some disease states that cause constipation, like irritable bowel disease. There are or like irritable bowel syndrome, which is IBS. Some patients, they are more constipated than like regular bowel movement. There are some medications or some foods that may cause constipation. They slow down the GI motility, especially with medications. A lot of them may cause it. I just gave you an example. What was that? What was the medication you just talked about?
With antacids.
Very good, antacids. So antacids which contain calcium or aluminum, they may cause constipation. So a very simple medication that is available everywhere, it may cause the problem. Iron supplement. So if the patient has anemia and the patient needs to be on iron tablets, one of the major adverse drug reaction, which is very bothering for patients and they don't like it, it causes constipation. Iron. And many other medications, of course. Okay, one big education for patients would be adequate fluid intake. Very important. Taking good fiber containing foods and fruits, and also a lot of fluid. Physical activity is always good for everything. Okay, treatment. In this section, what I want you to remember is for each of the classes for anti-constipation medications, I just want you to know, if I give you, for example, methylcellulose, I ask what kind of anti-constipation medication is this, and I want you to answer bulk forming. That's basically the only thing I want you to know, as well as if it's fast-acting or slow-acting. So the first ones are bulk forming laxative. And one example of that is methylcellulose. So if you go to pharmacies, there are some powders. People can take them, add some fluid like water to it, and drink it. So these are the bulk forming laxatives. Are they fast? No. They take a good day or two to start working. So if a person is constipated, it takes a couple days to start working. Stool softeners. For stool softeners, please remember Docusate. Docusate is an example of stool softener. Onset of action, again, they are not fast. So let's say if the patient is constipated and the patient needs to go to like an emergency surgery and we wanted to induce bowel movement, these are not going to work. They take time. So we need to give the patient something else. Stimulants. Stimulants are, the examples are Senna or Bizacodyl. These medications work much faster. So if we need to induce bowel movement, these are much faster. Like half a day or at most a day, they start working. Question?
What happens if someone overdoses on these? Like the obvious, but like does it really mess up their GI tract?
Sorry, what happened if somebody
Overdoses?
overdoses? For the most part, if you're talking about stool softeners and bulk forming agent, nothing specific. They are pretty benign medications. Maybe some GI discomfort. Okay. I don't want to say diarrhea. I don't believe they cause diarrhea, but may cause GI discomfort. But stimulants like Bizacodyl and Senna, they may cause diarrhea. So if the patient gets overdose of these, they cause diarrhea. But again, if the patient is on good fluid and electrolyte replacement, they're okay. After at most a day, they get much better. Okay? So these are more fast-acting agents. And then osmotic laxative, they are very fast-acting. So I mentioned 2 to 48 hours, but for the majority of cases, they work pretty fast. So for our patients in hospital, if we need to induce bowel movement, if they have a GI procedure or endoscopy, we can use this. Either lactulose, sorbitol, or magnesium salt, which is extremely effective. They work within a couple hours. So if I ask you which of the following agents is an osmotic agent or stool softener, please know the names and also remember which one is a slow acting, which one is fast acting.
So this one is the fastest one?
This is the fastest one. Yes, osmotic laxatives are the fastest one. After them, stimulants, and then stool softeners and bulk forming agents are pretty slow. So they are good for maintenance. If somebody has chronic constipation, the patient can be on methylcellulose like on daily basis. Diarrhea, we are going exactly to the opposite, the other part of the spectrum. Okay. With persistent diarrhea, fluid and electrolyte replacement is very important. That's the most important part. When we have a patient, any of us, if we see a patient, a family member, a friend with severe diarrhea, the most important thing, even more important than give a medication to slow down the GI movement, would be give the patient fluid and electrolyte. Because fluid and electrolyte imbalance can be fatal. Diarrhea on its own is not fatal. Okay? So a lot of time diarrhea can be caused by infections, like viral infections. A lot of time, we get sick for a day or two, and with nausea, vomiting, diarrhea. That's usually viral, and it's very transient. It's self-limiting. Some medications may cause diarrhea. With all the medications that we had today, which ones do you think they may cause diarrhea? There were a good number of them that may cause diarrhea.
The antacids.
Very good. Which one? Which antacids? Magnesium one. So please, very good. Please remember, any magnesium supplement, any antacid containing magnesium, oral, PO magnesium, causes diarrhea. Okay? So that's one. What else? Let me help you. When we talk about GERD, there was a medication that increased the GI motility, prokinetic agent. Do you remember the name? Methylcellulose? No. Metoclopramide. Metoclopramide causes increase in GI movement. So if the patient gets overdose, or sometimes even with regular dose, they may get diarrhea because it increases the peristalsis. Any other agent you think may cause diarrhea? Methylcellulose? No. Stimulants? Yes. How about osmotic agents? Osmotic laxatives? Yes. They may cause diarrhea also. One of them is magnesium again. Any magnesium containing supplement or antacid or bowel care agent may cause diarrhea. Okay, and there are some other medications, like some antibiotics may cause diarrhea. Some anti-cancer agents may cause diarrhea. Question.
I have a question. So I've seen at CVS those laxative with magnesium. What happens if you drink too much of those?
Okay, the question is in CVS, for example, or any other pharmacy, there are some laxatives containing magnesium, and they are OTC. That's the problem. So anybody can go and buy them. Okay. The problem is, number one, they may cause diarrhea. Okay. Number two is if the patient has a renal insufficiency, they get magnesium overdose very easily. So, and magnesium, like hypermagnesium, like higher level in the serum, may cause arrhythmia. So it can be easily pretty risky for a group of patients. Yeah, they are very effective bowel care agents, but they can cause problems. Any questions about, okay, so let's see here some disease states. So patients who have inflammatory bowel disease, like Crohn's or ulcerative colitis, they have like episodes of diarrhea. That's the part of the disease. And lactose intolerance can be the cause of that. Enzyme intolerance or enzyme deficiency. So if the person takes dairy product, they may have diarrhea. And I just mentioned about drugs. Okay, so how we treat diarrhea? So there are some agents, including bismuth subsalicylate. Bismuth is available OTC, over the counter. You can go to pharmacy and you see the suspensions, the pink one. Those are bismuth. A lot of people take them when they want to go to trips, especially out-of-country trips, so they have bismuth with themselves. Because bismuth has anti-diarrheal effect, it's also an antibiotic. So for short-term use, it's okay. For travelers' diarrhea, if somebody goes like out-of-country for a couple of days and they get diarrhea, bismuth is a good option. Loperamide binds to opioid receptors, but only in the GI. So it goes to the opioid receptors, bind to them, and it's opioid agonist, just like other opioids, but just in the GI. It doesn't go to the CNS, so it doesn't have opioid effects. It doesn't have analgesic effects, but it causes constipation. So in the case of diarrhea, loperamide is a good option. Diphenhydramine. Diphenhydramine also binds to opioid receptors and slows down the GI motility. The problem with diphenhydramine is some patients abuse the medication. So diphenhydramine may get absorbed a little bit and has some levels of opioid effects. So there are people who like to take diphenhydramine not for diarrhea, but just to have diphenhydramine. So for this reason, we always add atropine to diphenhydramine. And the reason for that is we don't want the person to take too much diphenhydramine. So when atropine is there, they get adverse drug reaction of atropine, so they don't like it. They don't take it too much. And the other thing is atropine is also antidiarrheal agent. Do you know why is that? Which mechanism atropine will work to reduce diarrhea? What is atropine? What's the increases the heart rate? Yes. Do you know how atropine increases the heart rate? Which receptor atropine? Beta? No. It's not alpha? No.
Calcium channel?
No. It's a cholinergic blocker agent. So it blocks muscarinic receptor. It blocks acetylcholine receptor. So this way it increases the heart rate. And whenever you're talking about cholinergic antagonists, think about constipation, think about dry mouth, think about urinary retention, think about dry eyes, so they dry the patient. Okay? When you think about cholinergic agonists, like pilocarpine, it's exactly the opposite way. So if you're giving your patient pilocarpine to increase the salivation, it may also cause diarrhea. So cholinergic effects, diarrhea. Anticholinergic effects like atropine, constipation. Okay? So in diarrhea, in the case of diarrhea, we can use atropine to reduce the GI movement. Do we use this combination? Yes, we use this very often in outpatient or inpatient setting. Okay, do you want to have a break? And then we continue the rest of GI. It's not a good topic for early morning. Nausea and vomiting. Okay.
I need to change the sponge thing.
Oh, yeah.
gonna go with me?
Wait, so is the oral? So the first is general. Is that all? Is that all? There's no picture, right?
I have a quick question.
Yeah.
For the okay, so you know how you said that for the antacids, the magnesium cause diarrhea,
Yeah.
but for the aluminum and calcium, it causes constipation. So what happens when you're taking magnesium plus calcium or aluminum? Does the body like go crazy because you're trying to constipate and have diarrhea?
No. Actually, they balance each other.
Okay.
Yeah. So a lot of antacids are a combination of magnesium and calcium.
Okay.
So some patients who get diarrhea from magnesium or constipation from calcium, they do much better with this combination.
Okay.
Yeah.
So it's
They
not
balance
like
each other.
okay. So it's not like you're trying to have diarrhea and constipation.
No, it's not like that.
Okay. All right. Sounds good. Thank
You
you.
know what? Actually, a lot of time, even if your patient has, let's say, osteoporosis,
Okay.
you may want to recommend your patient to take calcium. If they take calcium, they get constipated. Okay. So one way to overcome that situation is ask them to do it by some calcium magnesium.
Okay.
So if they go to any pharmacy, there are some bottles of calcium magnesium together. So if they take those, they don't get constipated. Yeah. But they don't get diarrhea.
Okay.
It's a kind of balance.
Oh, okay. Yeah, makes sense. Makes sense. Okay. Thank you.
But yeah, clinic was good. And radiographic.
I hope I was gonna do the ultrasound, but
Yeah, why?
I had set it up. It was good. It went well. Much better. And it was like she's like,
So it was what we had last week. It's just hard because like she has teenagers, so it's like it's like we're still no, but you can take those like you can take it well. And then I did. And then I was like, it's nothing to do with how we do yeah, that's kind of about that. I know. I started studying. I almost got into the first thing, the first lecture. I was like trying to like write on my own words. But then the first ever, I was like, oh, I don't know if this is gonna go or not really. Not really. I was just like, I don't think it was very effective. I was just like, there's so much to write. I feel like she wrote the period, and then she made like 8 pages into like 3 pages. You know? So it was like, that helped. But it was really I do all the then I go through and I so I'll like do everything. I don't have to. Everybody has that. Where did you get that? It was really good. Like probably like edit it and stuff, right? But it has all the yeah, but we're not getting tested on oral yet. But I'll need it still. That's why. Because we're unable. Look at it. But while we're in class, I don't think that like underlining but then I'll like look up a picture online and I'll have from the PowerPoint so I can have like a general idea of things like how they work. So I'll put like multiple pictures on for small but I know that all laid out. So it's like, oh, this is different from this because of that, and I'll just like reading. So we're all very, very hard. One day,
Okay, so let's continue. So the next topic would be nausea and vomiting, and we are talking about the treatment options for post-operative nausea and vomiting, pregnancy-related nausea and vomiting, and motion sickness. And as we go through the therapeutic options, we realize that for the majority of cases, we are using the same therapeutic options. There are a number of classes that we can use them for any of these situations. Okay. In regards to the post-operative nausea and vomiting, the agents or the classes that we can use are ondansetron or antiserotonergic medications. So as you remember, 5-HT is the other name, 5-hydroxytryptamine is the other name for serotonin. So if we antagonize serotonin type 3, we have anti-emetic effects. So antiserotonergic medications are antiemetic, and cetrons are all antiserotonin. So if you want to remember those, just remember cetron, pretty close to serotonin. Dexamethasone, which is an steroid, can be utilized to reduce nausea and vomiting, especially if we add steroids to classes like antiserotonergic agents, like cetrons. So in many cases, you may see patients is on a cetron, like ondansetron or granisetron, plus an steroid, like dexamethasone or prednisone or methylprednisolone, a combination of steroids and cetrons. Other medication or other classes that we can use are antiserotonin, anti-dopamine, antihistamine agents. They are a class, they are a group of medications that have all three of the effects. Anti-serotonin, which is anti-nausea and vomiting, anti-dopamine, which is again anti-nausea and vomiting, and antihistamine, which is anti-nausea and vomiting. So prochlorperazine is one of those agents. Promethazine, the same thing. So promethazine, the brand name, you may heard that. Phenergan is another agent that is antiemetic. So these all can be used post-operative. And post-operative means post-dental procedures or post-medical surgeries. The reason they are effective is whenever we are talking about post-operation or post-surgical nausea and vomiting, we are talking about using opioids during the surgery and after surgery. And as you know, one of the major adverse drug reactions of opioids would be nausea and vomiting. So in order to treat that, we can use any of these medications or a combination of these medications. The only combination that doesn't make sense that much is the last two, like prochlorperazine and promethazine, because they are both doing the same thing. So there's no point to use that combination. But any other combination here is good and effective. So for basically dental patients, if they are leaving the clinic with a prescription for Percocet, like oxycodone, acetaminophen, that may cause nausea and vomiting. So a lot of time, a dentist or other healthcare professionals there, they may prescribe a Cetron or something like an antihistamine, promethazine, Phenergan, or diphenhydramine, PRN, as needed if the patient gets nauseated. None of these agents are over the counter. All these agents need prescription. Can you think about any medication with similar effects and it's over the counter? Let's say there's a weekend, the patient has no option to go to a physician or dentist to get prescription. Something over the counter that has pretty close pharmacologic action. Look at the last two. Diphenhydramine, very good, Benadryl. I heard both, thank you. So antihistamines, especially first generation, type 1 antihistamines. Think about doxylamine, they are all over the counter. Benadryl or diphenhydramine, dimenhydrinate, they are a good number of antihistamine type 1 medications over the counter. So if there is no access to a medical team or dental team to write a prescription, the patient can go to the pharmacy and get some. Okay, and these are the ones. Antihistamines and dopamine antagonists. Okay, I'm talking about pregnancy-induced nausea and vomiting here, but you can also use these, the first one, antihistamines, for post-operative nausea and vomiting. Okay, so again, the majority of these classes can be used in any type of nausea and vomiting. So antihistamines are doxylamine. These are all first generation. Meclizine, first generation, diphenhydramine, and dimenhydrinate. Again, dopamine antagonists, just like post-surgical that we had them here, we can use them for pregnancy-induced nausea. Question?
Is it important to know each medication in these classes?
Yes. Actually, I asked question about classes of medication. So I may give you a number of medication, and I ask which of the following is antihistamine. Is that the question? Yeah. But at the same time, I want you to know that we can use meclizine or diphenhydramine in pregnancy-induced nausea and vomiting. Okay. Question? Okay. Other agents that we can use in pregnancy-induced nausea and vomiting, cetrons. cetrons are anti-serotonergic agents, so you can use them also. Any cetron. Glucocorticoids, it depends on the term. So look at the point here, must be avoided until 10 weeks due to risk of cleft plate in fetus. So until week 10, it's contraindicated. But after that, if the person has severe nausea and vomiting due to pregnancy, we can combine corticosteroids like dexamethasone with a cetron, or dexamethasone with an antihistamine. That's totally fine. It just depends on the time. Look at the last bullet. Post 10 week, safe to be used in refractory cases. What is that? What is refractory cases?
If it comes, the nausea comes back.
Exactly. Refractory means basically there is no other option. So you try all other options, they don't work. So the patient again has nausea and vomiting. If the patient is on cetron, antihistamine, antidopaminergic, they don't work. So we call them refractory. You may hear refractory disease or refractory symptom a lot in pharmacy, because we have some medication as last resort. We use them for refractory cases if no other medication work. Okay, another type of nausea and vomiting is motion sickness. It's a lot of vestibular, basically vestibular, visual, and somatosensory interruptions. So in these cases, when a person is very sensitive to sitting in a car, going to the road, or to be on board, like in a cruise, so the vestibular system gets interrupted. So even if they close the eyes and sit, they may get nauseated. In these cases, antihistamines and anticholinergic medications are extremely effective, especially anticholinergic ones. Antihistamines that have a lot of anticholinergic effects. There are some risk factors for motion sickness, like female sex, age, pregnancy due to hormonal changes, and also if the person has history or current migraine. Treatment options, antihistamines, anticholinergics, and look at anticholinergic, scopolamine patch. Have you ever heard of that? Scopolamine patch? They are available in pharmacies. I believe they are over the counter. I'm not sure, but I think they are over the counter. It's a very small round patch. The person just put that behind the ear. A few hours before going to trip or on board for a cruise, they put the patch behind the ear. It works pretty well. It induces a well control of not having nausea and vomiting. Other agents are antidopaminergics like metoclopramide and promethazine. They increase the peristalsis, so they reduce nausea and vomiting. And they also may have some anti-serotonergic effects, so effective medications. For the most part, what I ask you is the class of medications. So I give you medications, I ask you which of the following medications are prokinetic, like metoclopramide, because we know metoclopramide is prokinetic. We had that in GERD. Which of the following agent is antihistamine, first generation? Which of the following agent is anticholinergic? Or the other type of question is, which of the following agent can be used in post-operative nausea and vomiting? So indication and the class. If there is any specific adverse drug reaction that I mentioned, please remember that. Okay, there are some adverse drug reactions with each of these classes. So when we are talking about anti-serotonergic medications, the cetrons, anti-serotonergic, headache, constipation, dizziness. So we need to know that. For antihistamines, sedation, dry mouth, dry eye, urinary retention, we just dry the patient. with type 1 antihistamines. With antidopaminergic, think about Parkinson-like symptoms. Tardive dyskinesia, akathisia, and dystonia. These are all movement disorders, like involuntary muscle movement, muscle irritation, and the patient has like involuntary like movement, not purposefully. Tardive dyskinesia is you may have seen those patients when they move like their lips or their eyes, like facial movement, which is not voluntary and it's not purposefully. And unfortunately, there is one drawback about these medications. Medications which are antidopaminergic, like metoclopramide, look at the last bullet, metoclopramide or promethazine. If the patient gets tardive dyskinesia, those movement disorders, it may be irreversible. So that's why I personally do not recommend this class very fast. This is really my last resort for patients. Because even with lower doses, even in shorter period of the time, they can cause tardive dyskinesia. In the majority of cases, after discontinuation, the symptoms go away, but sometimes they stay. And it's very bothering for patients. Okay, this is when you see a patient on Reglan. Reglan is the brand name for metoclopramide. And you will see those patients. Unfortunately, they go to the physician for a GERD, they get a prescription for Reglan, and they never go back to physician. There is no appropriate follow-up. They are on Reglan for a long time. And after a couple months, they start having all these antidopaminergic adverse drug reactions. Any questions? Okay. So please, if you can, bring the slides for anxiolytics and insomnia. Okay, so can you tell me why we use anxiolytics? Because the patient has anxiety. So why we use anxiolytics? Let's say your patient necessarily doesn't have anxiety disorder, but you may want to use anxiolytics at your office, at your clinic.
Lower heart rate?
What's that?
Lower the heart rate?
Lower the heart rate? Yeah. Lower the heart rate because a lot of patients get panic when they come to dental clinics. A lot of patients are afraid you. Not you, but in general dental work. So, like me, whenever I go to dental clinic, I always ask for anxiolytics. Give me something. I want to sleep. Okay. So anxiolytics give the patient, basically patient will perceive a positive experience with vague memories of the minor medical or dental procedures. Do we use them? Yes, very common. A lot of patients, they're really afraid to go to dental offices, so easily we can control like the anxiety level and discomfort by giving them anxiolytics. So they may cause anterograde amnesia. What is anterograde amnesia? They cannot remember. So from the time they take the medication until at least a couple hours, they don't remember anything. Or if the medication is longer acting, they may not remember things or very vague memory of the day. Okay? So those medications are usually have anterograde amnesia effect. And for the most part, we use benzodiazepines that I'm going to talk about. Whenever we are talking about anxiolytics, we have to be careful about some of the precautions or possibly contraindications for using anxiolytic agents. So if the patient has significant cardiovascular disease, if the patient has a sleep apnea, if the patient has history of difficult tracheal intubation. So any kind of history of severe respiratory or cardiovascular problem. You know, I don't want to say all of these are contraindication. We just have to be more careful. Because if your patient has history of cardiovascular issues and you wanted to sedate the patient, you want to make sure your patient is stable. The cardiovascular function and pulmonary functions are stable. History of adverse drug reaction to sedation, of course, if the patient got benzodiazepine once and they had a lot of adverse effects, we probably don't want to use them again. For any medication, we do that. Current medications are very important. Why is that? Why current medications are important to you if you wanted to give your patient anxiolytics? Exactly, because of drug-drug interaction. If the patient is already on an opioid, and on the top of that, you wanted to give the patient another anxiolytic which has CNS depressing effect, then you may have too much of CNS depression. And that's not safe for the patient. Drug allergies, again, regardless of indication, regardless of the medication, we always, all of us, have to check the drug allergy whenever we want to prescribe, when we want to recommend, or when we want to dispense a medication to a patient. And alcohol or other substance abuse. So, in general, if the patient drinks alcohol, alcohol has some CNS depressing effect. On the top of that, if we give the patient other CNS depressing agents, it may be too much. So at least the time that the patient had alcohol is very important to us. Is it right before the appointment, or it was 2 nights ago, or it was last week? So the more recent, the more dangerous. The classes that we use are benzodiazepines, antihistamines. So you see antihistamines are everywhere. Did you know that antihistamines are such a useful? Seriously, until this point, we use them for allergy. We use them for rhinitis. We use them for nausea and vomiting. We use them for pruritus, like itching due to opioid use. And now you see that we use them as sedative agent. We use them for insomnia. So you may know people or family members or friends, if they cannot sleep, they go to a pharmacy, get some Benadryl, take the Benadryl at nighttime, and they sleep. So there are many indications for this class of medication. Narcotics also can be used, the other name for narcotics, of course, opioids and nitrous oxide. Okay, benzodiazepines, they bind to GABA receptors, and GABA is a depressing neurotransmitter. So if they bind to GABA and they are GABA agonists, they cause sedation. They cause CNS depression. So these are the effects. Please know them very well. They are sedative, they are anxiolytic, they have no analgesic effect. That's extremely important. If you think you put your patient on Valium and you relieve the pain, this is not true. So benzodiazepine do not do anything with pain. They also cause anterograde amnesia. So the patient cannot remember anything after he or she takes the medication for at least a couple hours. So this is GABA receptor. Benzodiazepines have a site on this receptor. They bind to it, they open the chloride channel, chloride goes inside the nerve cell and basically depress the CNS.
They remember that they have pain then?
Do they remember?
If there is a pain, they remember that?
During the procedure, no, they don't remember it. So so the question was, do they remember if the procedure was painful? Let's say extraction. They do not remember it.
They don't remember screaming and being in pain.
Okay, so the question is, if they scream and if they had a lot of discomfort, they do not remember that. But remember, when you give your patient anxiolytics, for the most part they are calm. So they do not scream. They are sedated at the same time. And if you use local anesthetic appropriately, then the pain is minimal. But even if they have discomfort, they don't remember that. Question?
So is this kind of, sort of, I remember there was, till now people sneak roofies, the roofie people, in the drinks and alcohol, the pills. Is this something like that?
Oh, okay. So we are going to like criminal mind thing.
No, but I don't know because they don't remember anything.
Yeah. Okay, yeah. Actually, yes. These are the same class of medications that, they can be used as criminal kind of purposes. The whole point is when the patient takes benzodiazepines, they do not remember this antagonist, the problem or the advantage. For medical or dental purposes, it's an advantage because the patient don't remember a couple hours after taking the medication. But in criminal situations, yes, that's exactly the case. The problem is, yes, same class of medication. So if somebody takes the medication, they do not remember. If they go to the party, if they drive, if they hit somebody in the road, they don't remember.
But during the process, are they like capable of making decisions? Are they drowsy or anything?
Okay, yeah, very good point. The question is when they are under the effect of the medication, are they functional? Yes, they are. So you may take a benzodiazepine, you leave the dental office, drive, go home, even in your way go do some shopping and then go home. Everything looks normal, but you don't remember. The problem is if something happened, if you, God forbid, go to an accident, hit somebody, you don't remember that part too. Okay? And you don't remember almost nothing about the procedure, dental procedure or medical. So good and bad. For medical purposes, they are extremely useful. Okay. You are so silent.
Scary.
Do you think that has any effect on memory if it's taken for a long time?
Very good question. Any long-term effect on memory only if the patient is on these medications for long-term. Yes, that's definitely one of the very important adverse drug reaction. If somebody is just taking benzodiazepine to sleep better, and he or she takes the medication for years, then chronic memory loss or early dementia can be one of the adverse effects. Okay, but for short term, for 1 or 2 doses for dental procedures, no. Yeah. Okay. Caution. Sedative, dizziness, amnesia, these all necessitate what? The patient to have a driver. So if the patient wants you to prescribe, or the dentist at your clinic to prescribe anxiolytics for them, they need to come with a driver. The driver, I think you know the policy here. When we go to dental clinic, the driver needs to sit there. They cannot leave the clinic. Because if they leave the clinic and they don't come back, you have a sedated patient. The patient cannot remember anything, you don't want that. So the driver needs to be there and they take them home. Okay. Diazepam is one of the agents. It's still gets used in medicine and dentistry as anxiolytic agent. The only problem with diazepam is it's long acting. So one thing I want to remember about this agent is it's long acting. So when a patient takes the medication, it has anxiolytic effects, but the sedation may take longer. So the patient is sedated for the rest of the day or even the day after. Is this good or bad? It depends on the case. If you have a patient, the dental work is done, the patient wants to go home and get rest, this can be a good option. But if the patient wants to go home and be really functional, let's say the patient has like nighttime work, and they don't want to be sedated all the night, all the day, we need to use shorter acting agents. Question?
A lot of people use these to travel on airplanes, right?
Yes, very useful. So, especially for long time flights or longer flights, long duration, it's good. But remember, you do not remember things. So if somebody takes this and they get sedated, and somebody get their passport, they don't remember anything. Somebody asks you, may I have your passport? And you give it to them, and they go, and they don't remember. Yeah. Question?
So can you prescribe us that, or?
You mean pharmacists can prescribe?
What? No, I was joking. I said, can you prescribe us some?
Oh.
Because we're taking a long trip for our mission trip, so we're like, what are we gonna do? It's like a 17-hour flight.
You know what?
Scary.
Okay. You know the thing is, if you have a like family physician or like on-campus physician, if you want to have 1 or 2 tablets just for the flight time, it's very common medication that patient take to sleep better. I am talking about other options too, but these are working for sure. So if somebody has really difficulty in flight, these are good options. I'm joking about passport things. It never happened though. So, any questions? Okay, so one thing about this medication is long-acting. It can be good or bad, but in the exam I may ask you, I give you 4 or 3 or 4 benzodiazepines, and I ask which one has the longer acting effect. I want you to remember this one and also this one, lorazepam and diazepam. These 2 agents, they work very well, but the sedation effect is pretty long. That's the only thing I want you to know about these 2. The next agent is triazolam. Triazolam or halcyon is one of the most popular anxiolytics that dentists prescribe. And the reason for that is the onset of action is pretty much similar to diazepam or lorazepam, about half an hour, 20 minutes to half an hour. So the best time to take it is while the patient is at the waiting room. So they come to the clinic with the driver. While they are in waiting room, they take the medication. They take the pill. So by the time they come to dental chair, they are sedated. And it's very interesting because from that time, they don't remember things. And they're pretty calm. But they basically follow the command. So if you ask them to work with them, to help to finish the dental work, they follow your command. Okay. Halcyon, a good thing about this medication, it's short acting, it's shorter duration. So if the patient has, let's say 1 hour, 45 minutes duration of the procedure, you want the patient to be sedated during that time, and then toward the evening time the patient is not sedated anymore, this is a good option. A lot of time dentists prescribe 1 tablet the night before and the 2nd tablet right before the procedure. And the reason for that is some patients get so panic about dental appointment, so the dentist want them to sleep better the night before, not be anxious. Okay. Midazolam is another short-acting agent. Very, very useful agent in medical procedures, dental procedures, in pediatrics, in kids. We can use it very safely. And, it's very short-acting. So the reversal is pretty fast. That's a good thing about midazolam. So we have 2 agents that are long-acting, diazepam and lorazepam, and 2 agents that are shorter-acting, triazolam and midazolam. If I ask you which of the following benzodiazepines or anxiolytic agent has the shortest duration, that's midazolam. Midazolam has shortest duration of sedation and anxiolytic effect. Okay. Other class of medication that you can utilize are antihistamines. But remember, they have to be antihistamines type 1, first generation. The ones that cause sedation. Like diphenhydramine, like hydroxyzine, like meclizine. Any first generation type 1 antihistamine medication causes sedation. The major difference would be they are not causing amnesia. So if you give your patient hydroxyzine or Benadryl during the dental procedure, they remember things. That's the difference. Okay? With benzos, they do not remember. With these, they are sedated. It's good that they are sedated. They are more calm. But they remember the things. The other good thing about this agent would be, what other thing would be good with these agents? Can you think about any other advantage of having an antihistamines during dental procedure or medical? They do not affect inflammation.
Can you give them pain meds with it too?
You can give pain meds to them, but they do not have any analgesic effect. But there is another characteristic that if you give some pain medications, okay, that's a good one. If you give some pain medications, they have some adverse effects that if you give them with these medications, the adverse effect is lower. Can you think about any adverse effect of analgesics that you may want to utilize antihistamines to relieve that? GI, what GI? Nausea and vomiting. So if the patient is on opioid, so let's say if a dentist gave the patient a dose of Percocet right before dental procedure, that Percocet may cause some nausea and vomiting. So if the patient takes that with hydroxyzine, nausea and vomiting is much lighter, or no nausea at all. So again, advantages and disadvantages. The other thing with type 1 antihistamine medication is they cause dry mouth. Dry mouth sometimes is beneficial for dental procedures. At least while you're working, dry mouth necessarily is not a bad thing. So for short term, it would be useful. The next agent is nitrous oxide, and I believe you have nitrous oxide in another course, is that right? Okay, so you know about this. The most important thing about nitrous oxide is it has sedative effect, amnesia effect, and analgesic effect. So all three. Analgesic effect, we didn't have analgesic effect with benzodiazepines. We didn't have analgesic effect with antihistamines. We didn't have amnesia with antihistamines. But we have amnesia, analgesic, and sedative effect with nitrous oxide. The other important thing about nitrous oxide is with oxygen, you can reverse it. So basically nitrous oxide works with concentration changes. So as the concentration goes up versus oxygen, you have more sedation. As the oxygen concentration goes up, which you can easily work with oxygen concentration or nitrous oxide concentration with the valves, then you can reverse the agent very fast. Within a couple minutes, it has the reversal. Okay. Insomnia. Some of the very general patient education or any person education regarding sleep hygiene, these are the ones, and I'm not going to ask any question on the exam because again our focus is pharmacology. What is good for you to know if somebody asks you, if the patient asks if they suffer insomnia, you can educate them for a good sleep hygiene. If they consider these and if they practice these, they may have much better sleep. Okay, medications that we can use. Benzodiazepines again. So we can use anxiolytics as a sleep aid. As you mentioned, like in airplane, as a sleep aid. But the whole point is we do not want to use benzodiazepines for long term. For short term, for as needed use, yes. For long term, they have detrimental effect on memory. So we don't want to put the patient on long term use of benzodiazepine. Non-benzodiazepine agents, please remember Z medications. Z medications are, I'm talking about those medications separately in another slide, but These medications are non-benzodiazepines, so chemically they are not benzodiazepines, but they work exactly on the same receptor. So they are not the same medications, but they go and bind to their receptors, the same receptors for benzodiazepines. If you want to remember them, they have a Z in their name, like Zolpidem. By any chance, do you know what's the brand name of Zolpidem? Zoloft? No. Zoloft is an antidepressant. Zolpidem is Ambien. Have you ever heard of Ambien? A sleep aid? It's pretty commonly used sleep aid. Then melatonin receptor agonist, or Rameltion, it's a very, very extremely benign medication. It's just melatonin agonist. So adverse drug reaction is very, very low. Orexin receptor antagonists are new class of medication. Orexin is apparently a receptor in the brain that activation of the receptor causes waking up. So people wake up when the orexin receptor is stimulated. So if we block the receptor, the patient can sleep for longer time. And the only medication in this class is suvorexant. Very new. I think suvorexant came to practice a couple of years ago. Other medications that we can use, again, first generation antihistamines. Diphenhydramine is an easy option. So if you really, let's say you're in the airport and you remember, okay, I have a long flight, I'm in the airport, I have nothing, I have no prescription for benzodiazepines, and I want to sleep. The least you can do is an antihistamine. If there is anything available in the airport, it's OTC, so get a couple of diphenhydramine or doxylamine. They are sleep aid. Okay, for the benzodiazepines, there are 5 of them that are FDA approved for insomnia, and these are the agents. So the only thing I want to know is the name. Just remember the name. Triazolam, temazepam, stazolam, flurazepam, and clozapam. So please just remember the name. These are FDA approved for insomnia, benzodiazepines that can be used. Let's see here, tolerance may develop, which is not good because after a few weeks or a few months, they may not be able to sleep with the same dose. We need to increase the dose, and of course this is not good. Residual daytime sedation, yes, especially with longer acting one. If you look at this table, there are 2 long acting one, so they may get some daytime sedation. Okay. Rebound insomnia. Again, if the patient is on benzodiazepine for a long period, like a few weeks or a few months, if we just discontinue the medication, insomnia gets worse. So it's a rebound insomnia. Of course, anterograde amnesia, I already talked about it. So one very important educational point for any person who wants to take this medication is what? What do you think? As a sleep aid, or in the plane, or at home. A very important point is, if you want to take the medication for better sleep, take the medication while you're in bed, or exactly the same time that you want to sleep. Do not take the medication and go do some shopping. Do not take the medication and watch the TV, because then you do not realize, you don't remember. You're watching the TV, then you get up, go outside the home, walk, you don't remember. So the most important thing is take the medication at the bedtime. Okay, and also we need to be careful about patients with hepatic and renal insufficiencies for any medication. So I'm not going to ask questions about this. This is a very general rule for any medication. If the patient has renal insufficiency or hepatic insufficiency, we need to be careful. With benzodiazepines, we also have withdrawal issue, like physical dependence, psychological dependence. Just think about opioids. and benzodiazepines. The same thing. If the person gets used to them, it's very hard to discontinue the medication. Okay, these are the Z medications. So these are non-benzodiazepines, GABA agonists. So structurally, chemically, they are different from benzodiazepines, but they bind to the same receptor, which is GABA receptor. And if you look at the names, Zaleplon, Ezopiclone, and Zolpidem. The most common medication that's prescribed for sleep aid is Zolpidem or Ambien. So just remember the names. Okay. On this slide, I do not ask any question. Don't worry about this. Oh, sorry. This slide is very important. Compared to benzodiazepine, Zolpidem, Zaleplon, and Ezopiclone do not have anti-epileptic properties. If you remember, in epilepsy, we can use benzodiazepine. Remember? Diazepam, lorazepam, clonazepam. But we cannot use the Z medications for epilepsy. The other thing is there is no muscle relaxant property. With benzodiazepine, they relax the muscle tone. With Z medications, except for very high doses, we do not have muscle relaxant effects. Much lower respiratory depression, so it's a kind of safer, lower risk of developing tolerance, although they develop tolerance. But the rate is lower than benzodiazepines, and they also cause anterograde amnesia. So if the person takes Ambien, again, go to bed. Do not do anything. If the person takes Zaleplon, just at the bedtime. Okay, other class of medication, Ramelteon or melatonin agonist. These medications just bind to the melatonin receptor in CNS, and they just basically help the circadian rhythm. So patient can sleep better because the effect of melatonin is more, basically, melatonin can be more effective, endogenous melatonin. I don't know about the effect though. I don't know how effective are melatonin agonists. I didn't study the references very well. But suvorexant is an orexin receptor antagonist. It doesn't cause that much of dependence, but it's a new agent that can be used. So just know the medication, suvorexant, and know which class of medication is it. Orexin receptor antagonist. So that's the only type of question I ask you. Other medications, again, think about antihistamines. You can use them like doxylamine, diphenhydramine, meclizine, any of first generation type 1 antihistamines. That's the only key point. So for the test or for the board, like H2R blockers, the ones that we use for GI, we do not use them for sleep aid. But the ones that are first generation type 1, we use for allergy, 9-time allergy, we can use them as a sleep aid also. Any questions? Question?
Are there any long-term effects of melatonin?
I don't think so. You know, in general, melatonin or melatonin agonists are extremely benign medications.
And what would you say the max dose every night would be?
For melatonin or for Ramelteon?
The
Melatonin,
melatonin.
as far as I know, 5 milligram, but it may be higher. I'm not sure. I can check it. Yeah, but I know that there are 5 milligram tablets that, for example, in the case of trip, like jet lag. So you can start melatonin, and it's OTC. You can start melatonin a couple of nights before the trip, during the trip, and during the flight, and then during the trip, the time that you're out of the country, for example. Yeah, 5 milligram for sure, maybe higher is okay. Question?
Is it true that if you take melatonin regularly, your body stops producing something, so that if you stop taking melatonin, then you're actually going to be dependent on it because your body stopped?
Okay, I see. So the question is if we get dependence to melatonin. As you know, melatonin is endogenous, and melatonin regulates the circadian rhythm. I don't know if you take melatonin for long term and you stop it, your body cannot produce endogenous, or I don't know. I don't think so, because the reason that I say I don't think so is if it was the case, they didn't make it as OTC. When it's over the counter, it shouldn't cause dependence. Any medication that causes dependence is usually prescription. Any question? So please study the material. I send you the study guide in a couple days. Study them. If you have any question, just send me an email or come to my office. So on the night, May 9th, please come to the class at 9 a.m. You only have the exam. No case, no course, just the exam. Thank you very much.
Just have to find like one of their groups. You're right here. There's a bunch of them. Concord. Just message these people. Oh. Never mind.
People are dead already.